You usually expect precision in medicine. Like, it's comforting to think of it almost like engineering.
Right, like you break a bone, you get an X-ray, there's a white line, and boom, the problem is defined.
Exactly. But, I mean, if you step into the world of pediatric nursing, that mechanical precision it completely vanishes.
Oh, totally. You're suddenly in this diagnostic landscape where, your patient literally can't tell you what hurts.
Right, and their anatomy is fundamentally different. A symptom that seems totally minor can escalate into a life-threatening crisis in, like, minutes.
It's arguably one of the most stressful transitions you'll face in clinical practice.
Yeah, so if you are about to tackle your pediatric respiratory module and you feel that heavy sense of overwhelm, you are not alone. It's a massive conceptual shift.
It really is. The golden rule you have to adopt right away is that treating kids is never just about shrinking down adult medicine.
Right, you aren't doing adult care on a smaller scale.
Exactly. You're operating in a completely different anatomical and physiological world. The margins for error are just so thin.
And that is exactly our mission for today's deep dive. We're going to decode the entire source material on pediatric respiratory disorders for you.
Yeah, we'll map out everything. The anatomical differences, breath sound assessments, upper and lower airway infections, all of it.
Right, plus congenital anomalies and the really specific crises of premature infants. So by the end of this, you'll have a crystal clear mental map of exactly what to look for.
And more importantly, why these tiny bodies react the way they do.
Let's jump right in and dismantle that mini-adult myth, because to understand the disorders, we really have to look at the physical architecture of a child's airway first.
Yeah, the sheer math of a pediatric airway is honestly sobering. It's significantly shorter and narrower.
I mean, in a newborn, that airway is roughly 4 millimeters in diameter.
4 millimeters, which
It's
is...
essentially the width of a cocktail straw.
Exactly, a cocktail straw.
To put that in perspective for you, imagine an adult gets, like, a common respiratory virus. Their airway lining swells by 1 millimeter.
Right. It's annoying, they sound raspy, maybe they complain a lot, but they're totally fine.
Yeah, but if that baby's 4 millimeter cocktail straw airway swells by 1 millimeter all the way around, that eats up 2 millimeters of total space.
Which means they've instantly lost 50% of their airway capacity.
50%. Over a cold.
Clinically, that triggers something called Pazuzu law. It basically states that airway resistance increases inversely with the fourth power of the radius.
Okay, in plain English for us non-physicists.
Right, sorry. In plain English, a tiny bit of swelling creates a massive exponential increase in how hard that child has to work just to pull air in.
So a simple cold that causes sniffles in a parent can literally throw an infant into severe respiratory distress.
Absolutely. And to make it even more precarious, newborns are obligatory nose breathers until they're about 4 weeks old.
Right, which evolutionarily allows them to nurse and breathe simultaneously, but it also means
They literally do not have the neurological reflex to just open their mouths to breathe if their noses get plugged with mucus.
that is terrifying.
Yeah.
And the physical structures supporting the airway are really immature too, right?
Yeah, they're super flexible. The larynx, the tracheal cartilage, it's almost floppy.
Because they lack that rigidity, just improper positioning. Like if you let a sleeping infant's chin slump down onto their chest, they can literally kink their airway closed.
Like stepping on a garden hose. And you have to remember the physiological engine driving all of this is their metabolism.
Because they're growing so rapidly. I mean, they double their brain size in the first year alone.
Exactly, which requires a massive amount of oxygen. So to meet that demand, they naturally just have a much higher respiratory rate.
And the mechanics of how they pull that air in look completely different to an adult, right?
Yeah, because their intercostal muscles, the ones between the ribs, they're underdeveloped. So they rely almost entirely on their diaphragm.
So you're going to see their little bellies doing all the heavy lifting when they breathe.
You'll also notice their respiratory rhythm is just irregular. Like periodic breathing, where they pause breathing for up to 15 seconds, is actually totally normal in a healthy newborn.
As long as there's no color change or drop in heart rate, right?
Right, exactly.
Okay, so knowing how small, floppy, and oxygen-hungry this system is completely changes how you approach an assessment.
It really does. You have to translate the visual signs of distress and, the sounds coming through your stethoscope.
So visual cues are your first line of defense. You're looking for nasal flaring, which is basically their instinctual attempt to widen that cocktail straw.
Right, and you're really looking for retractions. A child's chest wall is super soft and compliant.
So when their airway is blocked, the negative pressure they make to pull air in literally sucks their skin and soft tissue inward around their ribs.
Exactly. You'll see intercostal retractions between the ribs or subcostal retractions right below the rib cage.
You might even see head bobbing, which is just the child desperately using their neck muscles to help pull air in.
And once you auscultate, you have to map the sounds you hear to the actual pathophysiology.
Right, like crackles, sometimes called rails, which sounds like rubbing hair between your fingers next to your ear.
Yeah, that's the sound of air popping through alveoli that are just filled with fluid, like in pneumonia.
And because that fluid is deep down in the microscopic air sacs, crackles will not clear if the child coughs.
But if you hear romchi, which is more of a low-pitched, coarse, snoring sound, you're hearing air trying to push through thick, sticky secretions.
Right, and the larger bronchi, that's a huge hallmark of RSV, or respiratory syncytial virus, and cystic fibrosis.
Cystic fibrosis is such a great example of this. It's a genetic defect that stops chloride from moving to the cell surface.
So water doesn't follow, and the mucus gets incredibly thick and dehydrated.
Exactly. It basically turns the airway into a sludge trap. That's what causes those pronounced raunchy.
But unlike crackles, a forceful cough can actually move that sludge,
Yeah.
right?
Yeah.
So raunchy will often clear or change pitch after they cough.
Yes. These tell you exactly where the blockage is.
Right. Stridor is that harsh, crowing sound you hear during inspiration. It screams that there's an obstruction in the upper airway.
Like a swollen larynx from croup, or maybe they swallowed a coin?
And wheezing is that musical whistling sound, usually on expiration, which means air is struggling to pass through constricted, inflamed lower bronchioles.
The classic signature of asthma.
So all these signs really help you draw that critical clinical line between respiratory distress and respiratory failure.
Exactly. In distress, you'll see tachypnea, tachycardia, retractions. The child is working incredibly hard, but, and this is key, they're still compensating.
Okay, I have to ask the question that bothers every single nursing student during their first clinical rotation.
Oh, I know what you're going to ask.
You walk into a room to do an assessment, and the baby is just screaming at the top of their lungs. It raises your blood pressure. It's impossible to use your stethoscope.
Yeah.
But clinically speaking, a screaming baby is actually the best case scenario, isn't it?
So, a screaming baby is literally music to a pediatric nurse's ears.
Because it takes energy.
Exactly. It requires a huge amount of energy, lung volume, and oxygen reserve to produce a loud, sustained cry. If they are screaming, they are compensating.
Right. Whereas respiratory failure begins the moment those energy reserves run out. The compensation just breaks down.
And the mental status changes there are terrifying. They'll go from agitated and crying to just lethargic or confused.
You'll see cyanosis around the mouth. And you might hear grunting, which is actually a fascinating defense mechanism.
It really is. The child is exhaling against a partially closed glottis to create their own internal back pressure.
They're essentially building an internal splint to force their collapsing alveoli to stay open.
Right. It's called autopeep. Positive and expiratory pressure.
So when you hear grunting, see severe retractions, and notice a weak or totally absent cry, you are looking at an exhausted infant.
A silent, limp baby who is struggling to breathe is an immediate catastrophic emergency.
Wow. Okay, so let's move top down. That interconnected plumbing of a child's head and neck is where a lot of these problems start.
Right. Let's talk about ears. The eustachian tubes in a child's ear are shorter, wider, and a lot more horizontal than in an adult.
Which creates basically a superhighway for bacteria from the throat to travel straight into the middle ear. Hello, otitis media.
Exactly. With a bacterial or viral otitis media, looking through an otoscope shows this red, bulging eardrum from all the pus and pressure.
And then there's otitis media with effusion. Effusion just means a collection of fluid. So the middle ear fills with fluid, but there's no active infection.
Right. The child just feels this dull pressure, fullness, and often has some temporary hearing loss.
And we can't forget otitis externa, or swimmer's ear, which is just localized inflammation of the external ear canal itself.
For kids caught in a cycle of recurrent ear infections, surgeons will put in PE tubes or pressure equalizer tubes.
And parents are always terrified of this. They assume the tubes are permanent implants.
Yeah, so a huge part of your nursing role is educating them that these tiny tubes naturally fall out on their own as the eardrum heals, usually within 6 to 12 months.
That same parental anxiety definitely applies to tonsils. Tonsillitis causes massive swelling at the back of the throat.
We grade tonsil size from 1+ to 4+. A 4+ means they are so inflamed they're physically touching in the center of the airway.
The kissing tonsils, which obviously severely compromises swallowing and breathing.
So when a child gets a tonsillectomy and adenoidectomy, a TNA post-op care is entirely about airway protection and hemorrhage control.
Right, you position the child side-lying or prone, so blood and secretions drain out of the mouth instead of pooling over the airway.
And caregiver education has to be highly specific here. No acidic juices, no straws, because the sucking pressure can rip off the surgical scabs.
And absolutely no red-colored foods, like cherry popsicles.
But-
Because if they vomit, you need to know instantly if it's red dye or fresh hemorrhaging.
Exactly. You also try to minimize coughing or nose blowing, which spikes pressure in that delicate surgical bed.
Now, the most dangerous post-op complication is a slow bleed. And the stealthy, silent sign of a hemorrhage is continuous, repetitive swallowing while the child is resting quietly.
That is a massive red flag. Old, dark brown blood in vomit is normal. Bright, frank red blood is a 911 emergency.
While a slow post-op bleed is stealthy, sudden airway closure is the loud, terrifying threat, which brings us to the showdown between croup and epiglottitis.
Croup is generally viral. It announces itself with this harsh, seal-like, barky cough and inspiratory stridor.
And the inflammation usually peaks in the middle of the night, panicking parents everywhere.
To manage croup, we use corticosteroids to reduce systemic inflammation, cool mist, and a very specific nebulized medication, racemic epinephrine.
Right, racemic epinephrine stimulates alpha-adrenergic receptors in the airway's mucosal lining, which triggers rapid, intense vasoconstriction.
It physically shrinks the swollen tissue, opening the airway wide enough for the child to actually breathe.
But epiglottitis is a completely different beast. It's a rapid, aggressive bacterial infection, usually caused by Haemophilus influenza type B.
Thankfully, the Hive vaccine makes this super rare today, but when it happens, it is an absolute nightmare.
The clinical presentation is the 4 Ds and an S: drooling, dysphagia, which is difficulty swallowing, dysphonia, a muffled voice, distressed breathing, and stridor.
You'll usually see the child sitting up, leaning forward with their chin thrust out in a tripod position, just trying to keep air moving.
Now, the cardinal rule of epiglottitis is drilled into nursing students for a reason. If you see a kid drooling and struggling for air, human instinct begs you to grab a penlight and look down their throat to find the block.
Do not do it. You must never, under any circumstances, inspect the mouth or stimulate the back of the throat.
Because the epiglottis is sitting there like a swollen, furious red sherry. If you touch it with a tongue depressor or even just make them gag by opening wide.
You trigger a laryngospasm. The muscles violently contract, the airway snaps completely shut like a steel trap, and you cannot get air in.
You never look inside that mouth unless you have an anesthesiologist standing right next to you with a full intubation tray ready to establish a surgical airway.
It is truly life or death. So if the upper airway is about dodging total blockages, the lower airway is basically a relentless battle against cellular debris and spastic muscles.
Right, so let's talk bronchiolitis, which is primarily caused by RSV. It basically turns the lower lungs into a mucus factory.
It specifically targets kids under 2. The virus enters the mucosal cells in the bronchioles, replicates, and literally bursts the cells open.
Just creating a massive accumulation of dead cellular debris and triggering hyperactive mucus production.
These babies wheeze, they crackle, and because they don't know how to blow their noses, they literally drown in their own secretions.
Which means your most potent intervention isn't automatically cranking up the oxygen. It's deep nasal suctioning.
Exactly. Clearing out that debris often resolves the oxygen desaturation instantly. We also use 3% hypertonic saline nebulizers.
Right, purely relying on the mechanics of osmosis. You introduce a high concentration of salt into the airway, and water is pulled from the inflamed tissues into the thick mucus.
It thins the sludge out, making it so much easier for the child to cough up.
Now, preemies are highly susceptible to severe RSV, which is why high-risk infants get a prophylactic monoclonal antibody injection called Synagis.
They get it every single month during RSV season just to give their immune system a blueprint to fight it.
Asthma presents a totally different lower airway challenge.
Yeah.
It's chronic, obstructive, and inflammatory.
Exposure to a trigger causes the smooth muscles wrapped around the bronchioles to just violently spasm while simultaneously flooding the tubes with mucus.
And a persistent nighttime cough is a classic red flag that a child's asthma is poorly controlled and worsening.
Management relies heavily on the peak flow meter. A child blows into it when they're totally healthy to establish their personal best.
Right, and that number sets their green, yellow, and red zones, giving the family a customized, objective action plan for when to take a rescue inhaler or go to the ER.
We spend a lot of time educating families on metered dose inhalers. A child must use a plastic spacer chamber.
So the medication suspends in the air and actually gets down into the lungs rather than just blasting the back of their throat.
And crucially, if they're inhaling a corticosteroid, they have to rinse their mouth out afterward.
Because the steroid suppresses local immunity in the mouth, creating the perfect environment for oral thrush, a fungal infection, to just flourish.
The assessment of an asthmatic patient provides one of the most counterintuitive warnings in medicine.
I always look at it like a highway traffic jam. If you listen to their chest and hear loud, chaotic wheezing, it's like cars honking and squeezing past a lane closure. Air's still moving.
But if you're auscultating during a severe attack and suddenly there is a silent chest, you hear nothing at all, or just a harsh friction sound, the road is totally blocked.
Airflow has completely stopped. The sudden absence of wheezing during an asthma attack is a catastrophic sign of imminent respiratory arrest.
It's terrifying. But inflammation, mucus, and spasms all operate under the assumption that the respiratory plumbing was built correctly in the first place.
Which isn't always the case. Congenital anomalies rewrite those rules entirely, like esophageal atresia, or EA, and tracheoesophageal fistula, or TE.
Right. During early fetal development, the esophagus and trachea start as a single tube and are supposed to slowly zip apart into two separate pipelines.
If that process fails, you get structural chaos. EA occurs when the esophagus just ends in a blind pouch.
So the baby swallows milk, it hits a dead end, and comes right back up as frothy vomit.
And TE involves a fistula, an abnormal anatomical bridge directly connecting the esophagus to the trachea.
Which means every time the infant feeds, milk bypasses the stomach and pours directly through that bridge into the lungs.
The baby will instantly choke, cough, and turn cyanotic. This requires immediate surgical reconstruction.
Another developmental flaw is a congenital diaphragmatic hernia, or CDH. A physical hole forms in the diaphragm muscle.
So while the fetus is growing in the womb, their intestines, stomach, and sometimes even the liver migrate up through that hole into the chest cavity.
When the baby is born, you'll see a scaphoid abdomen. It looks severely sunken because the organs just aren't in the belly where they belong.
You'll actually hear bowel sounds when you listen to the chest.
And the life-threatening danger here isn't just the displaced organs. Because those bowels were taking up all the real estate in the chest during gestation, the lungs never had room to develop.
The infant is born with severe pulmonary hypoplasia, lungs that are dangerously small and underdeveloped.
Speaking of underdeveloped lungs, premature infants face such a harrowing journey, often transitioning from respiratory distress syndrome right into bronchopulmonary dysplasia.
Right. RDS strikes preemies born before 34 weeks gestation because their lungs simply haven't manufactured surfactant yet.
Surfactant is basically the biological lubricant of the respiratory system. Think of a tiny alveolus like a wet balloon.
If you've ever tried to blow up a brand new balloon that has moisture inside, the walls stick tightly together. It takes a massive, forceful breath to pop it open.
Exactly. Surfactant acts like a microscopic coating of soap inside that balloon, breaking the surface tension so the alveoli expand smoothly with minimal effort.
Without it, the lungs become stiff and rigid, and the air sacs collapse every time the baby exhales. On an X-ray, this looks like shattered ground glass.
To treat it, we literally give them the substance they lack. We thread an endotracheal tube down their airway and manually bag artificial surfactant directly into the lung tissue.
But herein lies the cruelest irony of neonatal nursing, doesn't it? The treatment for RDS often causes bronchopulmonary dysplasia, or BPD.
It's heartbreaking. To keep a premature infant alive, we have to push highly concentrated oxygen through mechanical ventilators to force those stiff, wet balloons open.
The sheer pressure of the ventilator, combined with oxygen toxicity, physically scars and damages the fragile lung tissue.
Almost half of preemies born before 29 weeks develop BPD. The scarring stiffens the lungs permanently and restricts the blood vessels,
Which leads to pulmonary hypertension, forcing the tiny heart to pump against immense resistance.
The nursing care for a BPD infant requires extreme discipline. It's called cluster care.
Because every single intervention costs the infant metabolic energy they desperately need for cellular repair.
Right. So every 3 to 4 hours, the nurse goes in, does the assessment, changes the diaper, checks vitals, and feeds the baby all at once.
And then you step away. You dim the lights, minimize noise, and do not touch them.
To offset the massive caloric burn of simply trying to breathe, their formula is highly fortified with extra calories too.
Premature brains also struggle to manage the basic rhythm of life, leading to apnea of prematurity. The immature respiratory center in the brainstem literally forgets to fire the signal to breathe.
Apnea is defined as a pause in breathing for more than 20 seconds, or a shorter pause if accompanied by a drop in heart rate or cyanosis.
We use CPAP to keep the airways stented open and physical stimulation like a firm rub on the chest or the soles of the feet to startle the brain back into action.
And amazingly, the primary pharmacological treatment is caffeine.
Which, giving caffeine to a 1-pound baby sounds absurd until you look at the pharmacology. It's a methylxanthine. It blocks the adenosine receptors in the brain.
Adenosine being the chemical that builds up and makes us feel sleepy.
Exactly. By blocking it, the caffeine chemically forces the brainstem to stay alert and continuously fire the respiratory drive.
But apnea isn't exclusive to preemies. Full-term infants can experience an ALTE, an apparent life-threatening event.
Which modern guidelines now refer to as a BREWE, a brief, resolved, unexplained event.
Right. This involves an infant under 4 months old who suddenly becomes cyanotic or pale, chokes, goes limp, and completely stops breathing.
Terrifyingly, half of these events happen while the infant is wide awake. The defining characteristic of a BRE is that the child spontaneously recovers or responds to brief stimulation.
Because they recover, it isn't categorized as SIDs, but it triggers a massive clinical hunt.
You have to rule out severe gastroesophageal reflux, hidden seizures, systemic sepsis, undetected cardiac arrhythmias. And tragically, you must assess for child abuse like shaken baby syndrome.
It's heavy stuff. But before we wrap up this clinical map, let's look at the daily reality of managing fluids for these vulnerable patients.
Oh, this is crucial for the module.
Yeah.
Kids have a much higher percentage of total body water and immature kidneys.
So giving adult fluid volumes would cause massive fluid overload and pulmonary edema in minutes.
This is why the daily maintenance fluid calculation, the 150-20 rule, is a life-saving absolute.
You allocate 100 milliliters per kilogram for the first 10 kilograms of the child's weight.
Then 50 milliliters per kilogram for the next 10 kilograms.
And finally, 20 milliliters per kilogram for any remaining weight above 20 kilos.
Right, so if you're treating a 25-kilogram child, you break it down mechanically. The first 10 kilos equal 1,000 milliliters.
The next 10 kilos equal 500 milliliters. So you've accounted for 20 kilos and 1,500 milliliters.
You have 5 kilos left. 5 times 20 is 100. Add it all together, and that child's absolute maximum daily volume is 1,600 milliliters.
Divide that by 24 hours, and you have a safe, exact hourly IV rate.
Perfect. Wow, we have mapped out an incredible amount of clinical territory today. We visualized the delicate physics of a 4-millimeter cocktail straw airway.
We translated the crackles, rhonchi, and stridor.
We dissected the catastrophic mechanics of laryngospasms and epiglottitis, the cellular debris of RSV, and the genetic sludge of cystic fibrosis.
Explored the developmental failures of EA, TE, and CDH, and outlined the rigid cluster care required for fragile BPD infants.
Right. And, the paradox of bronchopulmonary dysplasia is perhaps the most profound concept to carry forward into your clinical practice.
It perfectly encapsulates the razor's edge of pediatric medicine, the extreme pressure and concentrated oxygen we must force into a premature baby's lungs today to save their life.
Is the exact mechanism that scars their tissue and creates the chronic respiratory disease they will battle for years.
It's a delicate, incredible balance. Every single intervention, every millimeter of swelling, and every drop of fluid has an exponential ripple effect on a developing body.
You aren't just managing symptoms. You are protecting the entire future trajectory of their health. The next time you walk into a clinical room and hear a baby grunting or see the silent chest of an asthmatic, you won't just see the signs.
You'll understand the invisible physiological war happening beneath the surface.
Good luck on your exams, and we will catch you on the next deep dive.